Recording.
Hey, it's Dr. Bill with just the tip of urology school. And today we're going to tackle bladder cancer, muscle invasive bladder cancer. We talked about the superficial disease in previous videos. Bladder cancer is the second most common cancer we're going to see in urology. About 20 to 40% of the time, the patient is going to present with evidence of muscle invasive disease. About a third of those patients will already have evidence of metastatic disease. The standard of care for those patients with muscle invasive disease is going to be radical cystectomy plus pelvic lymph node dissection. There's actually evidence that supports a vigorous pelvic lymph node dissection in indicating that survival rates increase when this is appropriately done. For those patients who are not good candidates for a cystectomy or choose not to for other reasons, there are bladder preservation protocols, including aggressive resections of the bladder tumor along with chemotherapy and radiation. Transitional cell carcinoma is the most common. We also do see at a much lower rate squamous cell carcinoma and adenocarcinoma. Squamous cell carcinoma is interesting. It's seen at a higher rate in the Middle East because of a parasitic infestation, schistosomiasis. This parasite actually burrows through the urethra while people are swimming in the river and swims up the urethra to the bladder and burrows in to the urothelium of the bladder, causing chronic irritation, squamous cell carcinoma. Other forms of chronic irritation precipitating squamous cell would include bladder stones and chronic urinary tract infections and even chronic Foley catheter use. So those patients here in the US who are spinal cord injured, for instance, and who require indwelling catheters for years, it's appropriate to undergo periodic cystoscopy for evaluation. Remember your anatomy from previous videos, and transitional cells of the urothelium are common throughout the urethra, the bladder, the ureter, and the inside lining of the kidney. A field change defect disease, that's what we refer to bladder cancer as being a field change defect disease, and meaning that all of those anatomical areas are at risk for developing bladder cancer or urothelial cancers and need to be periodically evaluated. Imaging for those patients who have significant disease will include chest, abdomen, and pelvis, usually a CT with contrast or an MRI. Bone scans are not routinely ordered unless there's evidence of bone pain or laboratory evidence of bone breakdown. As most urologic cancers look at your TNM staging, giving us an idea of the volume of disease, any nodal involvement, and metastatic disease. Once patients have been appropriately evaluated and treatment is considered, if that patient is going to surgery for a radical cystectomy, cisplatin for a preoperative chemotherapeutic regimen is appropriate. For those patients who require adjuvant treatment or any treatment after definitive surgery, then other forms of chemotherapy, including immune therapy, can be considered. As always, when you're dealing with metastatic disease or dealing with a disease that shows evidence of penetration beyond in a point when our surgery can be curative, we need to involve the medical oncologist and sometimes the radiation oncologist. So certainly this is the case for bladder cancer. Once the patient patient and provider have decided on what kind of treatment is going to be required, and if cystectomy is going to be utilized, obviously consideration for a urinary diversion needs to be undertaken. The most common form of urinary diversion and been around for decades is the ileo loop conduit, basically a piece of ileum, small bowel, that has been separated from the small bowel intestine. The ureters are placed within that bowel, and a stoma is brought out through the abdominal wall for urinary diversion. There are other forms of urinary diversion that have developed in the last several decades. All include different types of bowel segment, and all have their own associated adverse risk associated with this, depending upon the type of bowel, the segment of bowel where in the intestinal tract that segment has been removed, and the length of bowel. Those will include fluid and electrolyte imbalances, potentially increased ammonium absorption, which can lead to encephalopathies, vitamin deficiencies, B12, increased risk for calcium oxalate stones, strictures, depending at the surgical anatomic anastomotic sites. So a variety of things that do require ongoing evaluation, and both with physical exam, radiologic considerations, and laboratory considerations. So when you see those patients, it's an important part of their care is to understand the segment of bowel, the length of bowel that was utilized. Again, look at the AUA core curriculum, look at up to date as far as some of the medical involvement that's required in surveillance for your post-cystectomy patients, and also have a good open relationship with your oncology colleagues. Very important for patient care and education, your own education in managing these patients. Again, Dr. Bill with Just the Tip of Urology School, working with muscle invasive bladder cancer.